This video is going to cover autism spectrum disorder as well as social communication disorder. Both of these diagnoses, we'll talk a little bit about the differences between the two and touch on how or what the counselor's role may be when you encounter either one of these issues. We're going to start with autism spectrum disorder, and this is page 50 of the DSM, I believe. Comes in terms of the order of the text, it comes after that social pragmatic communication disorder. But we're going to cover this one first just because it probably is the more common element that you will run into. And in the DSM-5, they revised this particular section. It's within neurodevelopmental disorder section, so these are issues that typically occur early in life, but they revised it and combined at least a couple of different diagnoses into what's called this autism spectrum disorder. Previously it was known either as autism or maybe even Asperger's, but now it's considered autism spectrum, or sometimes it'll just be referred to as someone being on the spectrum when they're referring to this particular element. So let's look first at the diagnostic criteria. You'll see this is 299.00. In Part A, you'll notice that there are no elements that need to be met, like 1 out of 2 or 2 out of 3. It doesn't have that kind of language in this criteria. What it says is persistent deficits in social communication and social interaction across multiple contexts, as manifested by the following, either currently or by history. And an important disclaimer here is that the examples that they give here are more illustrative, not exhaustive. So there's more ways that this element might be manifested or may manifest itself. This particular element is what is common with the social or pragmatic communication disorders. This is one of those elements. So you see, number 1, there are deficits in social and emotional reciprocity, that give and take of social interaction with emotional component. And it ranges, for example, from abnormal social approach, maybe a failure of normal back and forth conversation, maybe to a reduced sharing of interests, emotions, or affect. And it also could range to a failure to initiate or respond to social interactions. So it could be something a little different than what's called selective mutism, which is in an anxiety category here. This is really a real lack of social ability in all regards. So it could be just through communication, reciprocity, participating in conversation, not being able to have a normal back and forth conversation, a give and take. Number 2, deficits in nonverbal communication behaviors that are used for social interaction. For example, poorly integrated verbal and nonverbal communication. So it could be also a lack of eye contact, body language, or deficits in understanding and use of gestures. So they may not have great eye contact, may not have any eye contact. They may have very poor nonverbal skills, but what they're also lacking is understanding other people's gestures or facial expressions, their own nonverbals. So it's just a lack of awareness of themselves and what they display, and a lack of awareness in what other people, types of messages that are being sent to them. Could also be a total lack of facial expressions and total lack of nonverbal communication. In other words, it would just be kind of a flat presentation altogether. Number 3, deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various contexts to difficulties in sharing imaginative play or making friends, to an absence of interest in peers. All right. Hopefully that particular element is kind of self-explanatory, that it's um, just a lack of social awareness with other people. Part B, there is a restricted or repetitive patterns of behavior, interests, or activities that have manifested by at least two of the following, either currently or by history. Again, this is just illustrations, not an exhaustive list of what and the ways it might be manifested. And before I go on, let's just talk about the differences between A and B. A has to do with social communication. B has to do with behaviors, or maybe interests, things that they do. And there's going to be either a restricted ability, or restricted interests, or maybe there's just repetitive type behavior. Always needing the same things done, liking the same things. So, social element and then repetitive behaviors. Manifested by at least two of the following. So there is some criteria here with respect to this element. So one element that could or needs to be met, stereotyped or repetitive motor movements. Could be use of objects or speech. So some examples, some simple motor stereotypes, or lining up toys, needing things flipped, could be mannerisms of things that they're doing with their body, hand slapping. It really varies from child to child. Echolalia, which is repeating things that are said. And maybe there's idiosyncratic phrases that are just repeated ad nauseum. Second possibility, insistence on sameness, inflexibility, adherence to routines, ritualized patterns of verbal or nonverbal behavior. So for some examples here, extreme distress at small changes, difficulties with transitions, very rigid thinking patterns, have to do the same things each time you meet someone, need to take the same route or eat the same food every day. Again, just a lot of needing to keep things the same from day to day, minute to minute. Number 3, highly restricted, fixated interests that are abnormal in intensity or focus. So, for example, a strong attachment to or preoccupation with unusual objects, excessively circumscribed or perseverative interests, things that just continue year after year. The fourth element, hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So there might be an indifference to pain or temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. Now for this particular element, part B, I would refer you to a movie. If you're really wanting to see a great example of this, is to look up the movie Rain Man. There's two characters in it. The character with autism is played by Dustin Hoffman. And he has a lot of these symptoms right here, B1 through 4. If you've seen this movie before, you'll notice things that, when you reflect back on the movie, phrases that he repeated. Some of his rocking back and forth, which you see are the repetitive motor movements. Having to have things set a certain way. He repeated lots of things that his brother said to him. He needed to have a very specific routine about what time he ate, what time he watched the People's Court. He was very much fixated on, for example, watching People's Court. He was fixated on driving and being a good driver. had very limited interests. And he was also very hypersensitive to some of the stimuli that he encountered within the movie. So it's a great film to illustrate this particular element. Part C, symptoms must be present in the early developmental period, may not become fully manifested until social demands exceed limited capacities, or may be masked by learned strategies in later life. So people on the spectrum are going to be on a continuum. For more severe autistic behavior, it's probably recognized very early in life. As it falls on the continuum, it may become more apparent for those that are, less severe with symptoms, may become more apparent as they age. Probably going to be apparent by anywhere from, age 7 to 10, but it's later during that time in which it may become more obvious if they're not quite as severe with symptoms that are displayed. Lots of kids who are not on the spectrum disorder have some of these similar types of things about an insistence on sameness, having routines, fixated on a specific, TV show or toys or things like that. But as kids age, you can notice how it becomes a little more problematic with kids that are on the spectrum. For more severe cases, it'll be much more apparent earlier in life. But in order to meet the criteria for this disorder, all the criteria must be met in the early developmental period. And our favorite criteria, symptoms must cause clinically significant impairment in social, occupational, or other important areas of current functioning. That's that element we talked about one of the previous videos about a very common symptom for all the diagnoses, that it needs to cause some type of clinical significant impairment. E, disturbances are not better explained by an intellectual disability or perhaps a global developmental delay. So it can't be created by someone who's has some type of developmental delay. So that's all I want to cover with the autism spectrum. Let's move on to social pragmatic communication disorder. This is page 47. So it's a couple of pages before autism is covered. And I mainly have singled this particular element out because it may be another thing that upon presentation may confuse a diagnostician, a counselor, between this and a child being on the spectrum. This is going to be primarily an element with communication or that social ability. So you'll need to really distinguish if you encounter a child who is having some social and communication issues to see, is this communication disorder or is it issue of being on the spectrum. So they might meet the criteria for Part A of being on the spectrum, but not Part B. And therefore, you'd need to look at social pragmatic communication disorders. So let's look at some of the criteria here. Persistent difficulties in the social use of verbal, nonverbal communication is manifested by all of the following. Deficits in using communication for social purposes, such as greeting and sharing information. 2. Impairment of the ability to change communication to match context or the needs of the listener, such as speaking differently in a classroom than on a playground, talking differently to a child than to an adult, or avoiding use of overly formal language. So they're not really matching the way they're communicating to the appropriate context. They might talk to all the kids like they're talking to another adult. And in most day-to-day circumstances, kids talk to each other a certain way, and you notice that they will speak a little differently when they're speaking to an adult. Number 3, difficulties following rules for conversation and storytelling, such as taking turns in conversation, rephrasing when misunderstood, knowing how to use verbal and nonverbal signals to regulate the interaction. We'll just have a little bit more bizarre type behavior when it comes to the give and take exchange of speaking with someone. The 4th element is difficulties understanding what is not explicitly stated, non-literal ambiguous meanings of language. Just won't understand certain humor, metaphors. They'll be very concrete. Deficits result in functional limitations in effective communication, social participation, social relationships, their achievement in school, ability to work either by themselves or with others. Onset of the symptoms is in the early developmental period, but deficits may not become fully manifest until social communication demands exceed limited capacity. So again, as a child ages and more is expected of them as their peer group increases, and that's probably when it becomes a little more apparent. And symptoms are not attributable to another medical or neurological condition or to low abilities in domains of word structure and grammar, not better explained by autism spectrum disorder or the intellectual disability. So again, when you're working with a child in which you think might be on the spectrum, you're going to need to check for those repetitive mannerisms, the behaviors, the rigid adherence to routines, the hypersensitivity or hyposensitivity to certain stimuli. And that's the primary difference between autism spectrum and the social communication disorder. And as I cover this information, it's important for you to understand and be able to recognize a child who's on the spectrum. And it's important to realize that there might be certain limitations as to what you can do in terms of your role. You're trained to listen, to communicate, to intervene, to provide strategies, suggestions. A lot of what you do is based on communication. You're trained to pay attention to the verbal and nonverbal, and you're essentially asked to work with somebody who's limited in that capacity. And it's not something that if you just, think about it, well, I just need to train this person in how to communicate. It's not something that can be readily or easily learned. They are limited. This is a neurodevelopmental disorder. Their brains are manifested in a certain way that limits them and limits their abilities. So you have to really consider, what is it you can do? What's your role that you'll have as a counselor? And I've got some suggestions, some specifics, but I don't want you to think this is limiting, that what I'm telling you is that you should only do these things. This is, I guess, based on my own experience, this is where I've found the role that I've had when I've worked with kids who have been on the spectrum. And so I'm offering it as a suggestion that there's some things I think you can do, you can help with. And one of those is helping them develop awareness to that social give and take, the reciprocity of communication, of speaking when someone speaks to you, to it's okay to initiate conversation, to the general mannerisms of etiquette when it comes to communication. And a way to begin this process may simply be with a younger child is rolling a ball back and forth on the floor while you're talking. So you might both be sitting on the floor, have the child positioned on the opposite side of the room, and you take turns. You have a ball that you're rolling back and forth between the two of you, and it's a little bit of a game that you might start the game by saying, "How are you?" And then you roll the ball across the floor to the child, and they are taught that when the ball comes to them, they've been asked a question, then they respond, and then roll the ball back to you. And then it's your turn to participate in the conversation. You can go back and forth for a good bit of time just to help to reinforce the point of this communication, this exchange of dialogue. A second intervention could be helping the child to practice eye contact, and it could be done with the ball in conjunction with your rolling the ball activity. Add this dimension. Now, a more complex iteration of this particular intervention could be helping them to recognize facial expressions, various states of expressions. You might select some type of game related to emojis and helping them to discern and learn what different expressions are on a face. So that's kind of a concrete activity. Now, a third suggestion, which you would build off these other ones, is you help them to develop some social skills and how to make friends, just some simple skill building. Making friends could be something as simple as making conversation, having a little bit of a script that they can go to when it's they find themselves sitting across from somebody, a certain script of questions that they could ask and that they know to what particularly how to respond. So some questions examples could be, how are you? What do you like to do? What's your favorite color? What's your favorite toy? What's your favorite TV show? They just have kind of a go-to script that will help them to participate in discussion and dialogue. So those are just a few examples. There's obviously more complex elements that you can engage in with a child that's either on the spectrum or they have the social communication disorder. But I guess I've found in my own experience that these are some of the core skills that I have attempted to practice with the kids I've been working with, and found some success with them. I can't say that the kids, once I've finished our work together, that it means they're leading a happy and successful life. This is kind of a lifelong condition. Hate to use the term condition, but it's a lifelong diagnosis. And you really want them to have skills to be as successful as possible. The last element I wanted to mention when it comes to diagnosing a child on the spectrum is I would encourage you to make some initial thoughts or ideas that if a child really has come to you and they don't already have a diagnosis of being on the spectrum or their communication disorder or any other type of neurodevelopmental disorder, is it might be best in terms of the interests of your client that you give them some initial thoughts of there are some issues here, but then you really refer to a specialist for a diagnosis. So in my opinion, someone who's rendering a diagnosis of a child being on the spectrum probably should come from a psychologist or someone who definitely specializes in recognition and diagnosis of autism spectrum disorder. I'm going to post a link to the Autism Speaks website and there's be a specific element on their site that's, I think it says where to get a diagnosis. And what I just want to point your attention to as you investigate that link is that there does not seem to be any LPCs on this list. So that should be a little bit of reinforcement with my suggestion to you. If you have these suspicions of a child being on the spectrum, is help the family to identify that this is an issue and then refer them to a specialist for a diagnosis. And there are some highly specialized facilities and sites in North Carolina that has improved over time, being more and more locations. Once upon a time, there was primarily just the Teach resource, and it was affiliated with UNC Chapel Hill. I remember seeing some clients that I needed to refer them to Teach, and they probably had about a year and a half wait just to get the child in and get them seen. So it's great that there's more facilities, more support in this area. The Autism Speaks website is a good resource to have at your disposal to know perhaps where to refer when you encounter this. So that's it. Let me know if you have any questions.